Hello everyone, thank you for attending today's session. For those of you that don't know me, my name's Kim Steady and I'm the Adult Social Care Strategic Oversight and Development Lead. Currently within adult social care, we are exploring different assistive technologies to help us support citizens within Hounslow to live well for longer. It is with great pleasure that I offer the virtual floor to Steve Careful of PA Consulting and Mark Allen of Hampshire County Council to talk to you about some of the excellent assistive technology tools they have within Hampshire. So without further ado, I'm going to hand over for everyone to enjoy the session.
Hi everyone, Mark Allen here from Hampshire County Council. As you can see from the slide there, I hope you can see the slides. I'm Head of Digitally Enabled Care for the County Council, and my colleague Steve, if you want to introduce yourself, Steve.
Yep. Hello, I'm Steve Careful from PA Consulting and Argenti also, which is the name we have given to the managed service in Hampshire for care technology.
Cool, thank you, Steve. Right, it's a real pleasure to be talking to you today. Effectively, we are going to be giving you three presentations. We're going to start off with some background about what we do. I think we both think that's really quite important. You understand the sort of basis of our platform that we use, we've developed over the years, and the partnership we've got between the County Council and PA Consulting, or Argenti as the sort of partnership's called. And then we're going to talk about the Alexa project that we currently run and ran a few years as a pilot and have mainstreamed. And then we're going to be talking about some work that we're currently doing, which is around the use of cobots, which are called cooperative robots. They're sort of worn exoskeleton type things, but we'll come onto that and you can see a video. So we've got a couple of videos throughout this as well. But we are going to start off with looking at our approach to delivering care technology, which is something we've been working on since 2013. So I'll start rolling through these slides. So I'm going to start and then Steve will take over. So just to give you some context, this is a image of Hampshire. It's an area that covers 1,400 square miles. There are urban bits. You can see the areas with the in bold, so Basingstoke, Winchester, Southampton and Portsmouth are the largely urban areas of Hampshire. Southampton and Portsmouth are not part of Hampshire County Council. To give you some context of that, I was looking earlier today and I think the Hounslow area has got a population of about 270,000. Portsmouth, in the small peninsula down the bottom there, has got a population of about 240,000. So it's slightly smaller than Hounslow, but it gives you an indication of this sort of like the geographical spread. Portsmouth's probably a slightly smaller area than Hounslow, but Hampshire is a big rural area, and I think in terms of the stats on that, we're 20% urban, 80% rural, but the populations are 80% in the urban areas and 20% in the rural areas. So we've got some real challenges about how we deliver services. In terms of the county as itself, in terms of the demographics, it's a population of about 1.3 million people. We've got an older person's population. I think we need to look at these figures because they're higher than this now, but it's in excess of 235,000 people over the age of 65. And we've currently got around about, with formal care packages, around 9,000 people supported at home. As a county council, we're spending probably around, still, even with the cuts, we've looked at over the last few years, probably in excess of £1 million a day on social care. So I think our social care and public health budget is over 400 million, which is a significant amount of money to support those individuals. But we, like you, will be facing a number of challenges. Those challenges in particular are there are more people needing care with more complex needs. and we are looking at fewer people who want to work in social care. It's a real challenge for us in particular, and I think the things that have been happening over the last couple of years are both economically and socially mean that the pool of people that we can draw on to help work in social care is diminishing. So I think in terms of how we've developed our approach to delivering care technology, it's probably worth understanding where we started from, and this is often useful for authorities because it sort of demonstrates that sort of journey that's been taken. We started looking at this in 2012, 2013, and back in 2013 we effectively had 10 different suppliers of what we call telecare tech across the county then. Most of them were sort of like small housing providers with basic services. One or two of the other boroughs. We're a two-tier authority, so we've got district and boroughs as well as ourselves. We had services that provided us with very little feedback on what was being provided, and particularly the impact on individuals. It was very driven by numbers, not outcomes for service users. So there was a very strong, from those providers, they measured their success by the numbers of connections they had, not what they were delivering. Or that wasn't for all of them, but most of them it was. And that from our perspective, services were provided as well as, not instead of, other services. So it was really a case of everybody got on with delivering their social care as they always did, and then if it felt like it was something that could be done, then they'd bolt on a bit of tech, and that was great. And it was fair to say that we had no vision and no real plan about how we were going to utilise tech services going forward. For me, it was a very sort of like a poor set of service offer that we had, and we probably only had about 500 people, round about 500 people that provided tech as part of an assessed package of care. So the picture now is very different. We've got a partnership between ourselves and PA Argenti. 97% of the users of tech services recommend it, and 9 out of 10 social workers say it achieves the desired outcomes that they actually assessed in the initial phase. It's focused on outcomes and benefits, boxes and wires, and it's often the first option that's considered when care is being planned, and through the discussion with the cared for person and family, that's actually discussed as part of the ongoing option. And we've probably got, actually it says 12,000, it's probably nearer 13,000 people there with tech services, and it's probably worth emphasising that the vast majority of those individuals have gone through some sort of care assessment. So they're not people who fancy a bit of tech or whatever, or are prepared to pay for it. These are people who have gone through a formal Section 47 assessment for their care needs, and that we've been able to evidence in excess of £15 million worth of cost efficiencies over the period since 2013 to today. And it says there we've won multiple sector awards because actually I think it's recognised that what we do is good. I think moving on to the next bit is I think one of the things that we often get asked is how do we do this, and how do we put care at the heart of the care offer, put tech at the heart of the care offer. There's some real there's no magic wand to this, and there's no silver bullet. And one of the things that we did do is that we recognised that we weren't the experts in this field, that we needed to actually work with people who were. And I've got a sort of what I feel probably is a very hackneyed old saying nowadays, but it's let the experts be the experts they are, which is social workers are experts at being social workers, and our tech colleagues are the experts at being techs. And what we need to do is get those two sets of people working together effectively. So our focus nowadays is on understanding outcomes, and for us those are 3 levels, which are understanding outcomes for the service user, understanding the outcomes for us as an organisation, and often that will be what are those sort of higher level benefits that we'd be seeking to achieve, like cost efficiencies, and also what are the outcomes that we can demonstrate for the system. So how does it help the system, the health and social care system, operate more effectively? We've had a very, very strong emphasis on working in true partnerships. So there's a lot of work being undertaken to develop our partnership and make that a meaningful thing. There is very, very significant focus on changing behaviours. I think if you want to do anything that's really meaningful around melding in and looking at how you combine in technology to more traditional forms of care and service delivery, behaviour change is a very significant element of that. We embed innovation, and I think one of the things that is really critical here too is acknowledge that innovation isn't just a shiny new piece of tech. It's actually often more about the ways of working and how you actually introduce technology into that than the shiny bit of tech. We are slightly obsessed about monitoring performance, and that's probably common across the board nowadays. We've got a number of dashboards that help us look at that, and also that tracking of benefits is very significant there. So I'm going to hand over to Steve now.
Okay, thank you very much, Mark. I'm not going to put my video on if you don't mind, not because I'm shy, but because I have a fairly flaky Wi-Fi connection. I don't want to lose the sound. So I'm going to pick up the points that were at the end of Mark's last slide there about the thing that the council focuses on, and explain a bit about what that means in practice. So the partnership working, changing behaviours, embedding innovation, and monitoring performance and tracking benefits. So first of all, what does working in true partnership mean? We go to the next slide, Mark.
Oh, sorry.
So the term that's been coined in Hampshire is a developmental partnership, and what's at the root of that is Mark's point about recognising that while social workers have a really key role in understanding service user needs and outcomes, they weren't necessarily the experts on the technical side. So bringing the two sides together, creating this partnership that responded to needs, developed the service, flexed in ways that meant outcomes could be achieved more cost effectively or more quickly, is really at the heart of the way that we work together. And what that means in practice is some of the things around this little diagram. So the one that I like is in the top right hand corner there, respected challenge. It's not uncommon as a provider of services into local authorities to be in a situation where the commissioner tells you exactly what to do, and even if what they tell you to do perhaps isn't necessarily the right way to go about something, you as the provider are almost obliged to do it because that's what your commissioner's asked for. It's completely different in Hampshire. We'll sit down together and look at the outcome we want to achieve. And if there is a suggestion from the council that we think actually that's not going to help achieve that outcome, we are invited and encouraged to say so, because they recognise that together we're probably two heads is better than one, and we can achieve a better outcome if we have that open conversation. We scroll round to kind of 6 o'clock on that slide. Management information is really important. Really understanding what's going on in terms of who's got care technology, where the referrals are coming from, what outcomes are being achieved, absolutely critical for steering the service, and not just using that as a rear view mirror to see how things have gone, but using it to determine how things are done in the future in a very active way. And something that when I work in other local authorities, and I've probably been in 25 or more different local authority care technology services over the last decade, something that's often very lacking is that insight and information. So people are designing and delivering the service by gut feel or the seat of the pants, or this is the way we've always done it, and in contrast to Hampshire, where we've been able to be much more driven by data and information and insight. And then I'll finish with the top left-hand corner, the kind of 11 o'clock position, shared ambition and joint objectives. The whole enterprise is designed around achieving those objectives that Mark mentioned on the previous slide. So what do we want the service user outcome to be? Is it they want to stay at home longer? Is it they want to avoid a long lie if they have a fall? Is it that they want to continue to go out into the community without the fear of being lost or getting into a difficulty? The focus on those, on achieving the kinds of savings figures that Mark has identified as well, and also that system change, getting social workers and others who are providing care services or prescribing care services to think differently about technology. we are all on the same page in terms of our desire to achieve those ambitions, and we set the goals and the performance intensives and the targets and the monitoring reports all around those objectives. So one thing that Mark has said on a number of occasions to visiting visitors from other authorities who often come having heard that Hampshire's doing a really good job and expecting to see very highly technical new solutions they've never heard of being used. What they discover is we do use some of those things, and we're going to go on in a minute to talk about Amazon Alexa and cobots, but actually the bulk of what we provide is relatively standard stuff. It's the way it's done that's important, and the reason for that is that will achieve the outcome. There isn't a need, if you're focused on the outcome, to necessarily have bleeding edge technology that was developed by NASA last week. Very familiar devices, lifelines, pendants, bed sensors, chair sensors, occupancy sensors for door exit sensors. All these things that have been around for years will do a really good job if you're focused on the outcome, and that's what determines what you install. And the difficult thing is getting everybody rowing in the same direction rather than finding the technology. The technology is almost always available as long as you define what you're trying to achieve with it first. So that's what working as a developmental partnership means. If we move on, Mark. Mark made the point that it's really important that there is that the culture change is at the heart of this. Again, it's not about buying the latest kit. It's about getting everybody in the system to recognise the value that can be added by care technology, complementing other forms of care. So we've got a whole array of different things that get done in Hampshire on a routine basis. And looking back over the 7 years we've been there, this is probably the area where we probably underestimated how much effort was going to be required. We had the view that within 6 or 9 months we'd have trained virtually everybody. Everyone will know what this is, and they'll just do it naturally. And actually, what we found is partly because of turnover of staff and new people coming in, and you have to train them, but also because you just have to constantly remind people and repeat the messages, repeat the good case examples, give people that reason for making a care technology referral. This has never ended. So, Mark, you might as well fly all of the things in here. So, top left, we've got formal training. That goes without saying. Top right, we have a very established network of champions. We've got about 60 champions identified across the county. At any one time, about 3 dozen of those will be actively involved, coming to meetings, sharing messages to and fro. Lots of communication in that bottom right-hand corner, internal communication, external website videos, case stories, high quality materials explaining what the service is and what it does, and giving people examples of where it's helped individuals in different circumstances. And then lots of on-the-job training and support as well. So we have secondees into our team from the council. So we have a social worker and we have an admin person who work with us. And a lot of effort goes into rapidly responding to queries, helping social workers answer the question, could care technology help my service user who's got these issues and we need to achieve these outcomes? That's a very active process. Okay, next. So innovation is embedded. We have newsletters, we have innovation panels, we have an evaluation process that lets us look at new solutions, because nowadays we're probably approached, I would say, probably every couple of weeks by somebody who's invented a new device that's designed to help support people with care needs. Some of these are very effective and useful, and some of them less so. And you obviously can't be using the things that aren't going to work consistently and effectively when people's lives may be dependent on it. So we have an evaluation process, and that both reviews and evaluates the technical capability of the thing, but also things like lifetime cost, how easy it is to maintain something, because if something breaks and you have to get an engineer out, it's quite costly to go around to somebody's home and fix something. All those factors get taken into account. There's a couple more clicks on this slide, Mark, and that's led us. Sorry, can you just go back one step? So that's led us to introduce things like Amazon Echo, and we're going to talk about that in the next in the next segment of the presentation. But some of the solutions that we've developed have been very, very simple. So that little phone on the left-hand side with the red button on the back, that was a response to the challenge of helping people get out of hospital quickly. And with a device in their hand they could go home with that would connect them to the monitoring centre if they had an incident or some kind of problem within the first day or so of getting home, before we'd had time to go in and do a full care technology assessment and install it. So we now give these out in hospitals. They're called SOS phones. They're £30 phones with a SIM card in. You program them in advance to connect to the monitoring centre, so the monitoring centre knows who has the handset, and people go home with that device, and then there's a proper installation following. That device is retrieved and put back into the hospital discharge team, and that way we're giving people that element of safety and security just in that short period between hospital discharge and a full care technology install. Next slide, Mark. Mark's talked about the obsession with data. This is just an extract from a data dashboard that we use to show where we are with referrals coming in, where the referrals are coming from by team, how referrals are looking relative to previous months, and the council use this with us to identify low-performing, low-referring teams. So we then go out and give them extra support and help to make sure they understand the benefits of care technology, and then making the quantity of referrals that other teams are making. So it's a relative thing. There isn't a particularly fixed idea of what the right number of referrals is, because it may vary from location to location. But if one team can manage 60% of the people they assess getting a referral for telecare, then the care technology, then the next door team probably should be in the same ballpark as well. So that's useful insight for driving the service. Next slide, Mark. So the one thing there isn't a slide on, which I'll just mention because Mark mentioned it in his slide, is the savings figure, or the net efficiencies. There's a lot of effort goes into ensuring we understand what the benefits are that are being driven, and Mark mentioned this thing about care technology being used instead of rather than as well as the rest of the package of care. We work very closely with the social workers to help them understand, if we give somebody care technology, does that mean they can be supported effectively and achieve their outcomes with a slightly lower level of dom care, or will the care technology keep them out of residential care for a little bit longer, even if that's only a matter of weeks or months? And all those little incremental benefits are tracked at the individual level and then aggregated up, and the cost of the service is then netted off that, and that gives us the figure of 15 million over 7 years that Mark talked about before, which is very robustly evidenced within the Hampshire system. Okay.
Thanks for that. I think, given the time, should we move straight onto the Alexa? We can take questions overall at the end, if that's okay. Right, I'm going to stop sharing these slides and put up the Alexa pack, if that's okay. Okay, so this one. All right, hopefully you're seeing that.
Yeah, that's good.
Good, right. Again, it's me kicking off this. Partway through this, we've got a short video to show you that hopefully illustrates the sort of value that this project brings. This was one of those projects that I just loved because you'll see in the video, it was one thing, the device itself is actually really quite simple, but the impact it has on people's lives can be significant. And it's the sort of thing that they'll have in their home that they might have been bought at Christmas but never thought to use effectively. So what we wanted to do in this, so this was really about us exploring how we could use the Amazon Alexa. We chose the Alexa because it was a device we all knew and was available, plus PA Consulting have got a sort of developmental partnership with Amazon Web Services, so it sort of made sense. But it applies to any of these sort of consumer connected devices, the sort of smart speakers that sit in your home. So the aims of this trial was really, when we were looking at this, one of the things that we wanted to do was to say, actually, how could we start as a local authority to move away from this sort of the normal stuff you buy as a social care organisation or a local authority in terms of the telecare stuff, you know, the normal stuff that Tunstall churn out or John Tech or whatever, and how could we start to look at consumer connected devices, CCDs as we call them, and how could we actually use those to deliver outcomes. And we started this with a very open mind in terms of the sorts of outcomes that we might see. We didn't really know. What we wanted to do was to assess the impact on care provision, identify the pros and cons of using these devices in those sorts of settings and with individuals that may have really quite varying needs and different age groups, etc., and decide if and when those devices should be part of our business as usual tech offer. And we received some funding from the LGA local investment programme to do this. We've had a few good hits from them in terms of actually enabling us to look at various things, and we've had funding from them to undertake the cobots work as well. So the method we employed was we wanted to select about 50 individuals. So these were all people with assessed care needs. We decided that we would supply each of them with an Echo Dot, so we used the dots instead of the big speakers. And that we may include some additional devices there, so it could have been light bulbs or plugs or whatever. And we needed to agree with each of those individuals what their desired outcomes were, because it was pointless us just throwing a piece of tech into their rooms and saying into their homes and just going, we'll use it. What we needed to understand was, what did they want to do with this? What are the sorts of outcomes that these individuals with varying levels of disability or impairment or whatever would want to see how it could be used. We discussed data and consent with them, and I think there's a real important points here, and Steve will go on to talk about some of these. We needed to curate relevant skills. So one of the things that we found was, and I think we may not say this in the later part of the thing, but one of the outcomes of this is the role of a curator as local authority is quite important in these sorts of approaches. We needed to be able to connect to peripherals and undertake repeat revisits if required, and I think Steve will say more about that and about the implications of that. And we undertook before and after surveys so that we could evaluate the impact for those individuals. In terms of the users that we were working with, 70% of those had a physical disability, for example, multiple sclerosis and cerebral palsy. And I think the sort of acquired brain injury area was one that was particularly people were particularly interested in, where they had impacts on their ability for movement. 16% had a visual impairment, 14% were elderly or frail, and 60% female and 40% male. They were all adults aged over the age of 16, but the oldest was 93. Therefore, busting the myth about particularly older people can't use technology. They absolutely can. The interesting thing was all of them needed to actually sign up for an Amazon account, and they needed Wi-Fi in their home. It's one of those areas where there was no other way of doing it. We couldn't get around that. And that we were not looking at meeting life critical dependencies via the Echo. It just was not on the agenda, and that all had access to carer backup, so that they weren't just becoming dependent on the Echo for this trial period at least. So I'll hand over to Steve. I think we're going to play a video now anyway. To Steve.
Yep, I think we'll just go straight into the video because it speaks for itself. Yeah. Chris, if you can run that.
Yep. Do I stop sharing at this point? Okay.
There's a crisis in adult social care, and a lot of it's down to the cost of providing a carer. But what if you could use technology to do some of that work? That's just what Hampshire County Council is trialling, as our reporter Hannah Bewley has been finding out.
Alexa, play Barry Manilow.
Shuffling songs by Barry Manilow. You know I can't smile without you.
because Claire's got MS, she's stuck in the chair and can't move around herself now. It is really important that she is independent as much as possible.
Claire and Eric Williams in Fareham are one of 50 households in Hampshire to be given an Amazon Echo device by the County Council. They're part of a £50,000 trial to see how new technology can help elderly or disabled people in their homes.
I can go out now without having to worry how long I'm out for, because Claire can actually ring me and talk to me.
Alexa, stop.
But can a virtual assistant be a substitute for a carer?
I mean, it doesn't do the physical side of things, but for a carer to come in, that costs money. So this doesn't actually cost any money apart from the initial setup of buying the box.
You need other stuff rather than just physical stuff. Your mental well-being. You need to have an interest. I like reading books. Does that for me. Don't think it could do a Sudoku for me.
That would be cheating.
Alexa, lamp on.
You all know there's a crisis in adult social care, and a lot.
Okay, thanks, Chris. Mark, will you return to the slides? Okay, thanks. Move on to the next one. Right, so Mark's outlined what we were seeking to achieve and how we went about it. So the results here, you can see on the left-hand side there's some percentages. These are based on self-reported views from those who are involved in the service. So they are their personal responses to the experience of having the device. And in broad terms, we've found a significant impact on feelings of independence and isolation. So you heard Claire there talking about the ability for the device to read her a book, turning the light on. You can imagine at this time of year, she can't get up and reach for the lamp or the light switch, so she's dependent on Eric to come in and do that for her. So just that small change was enough to give her that sense that she still had some control and independence that maybe had diminished due to her condition. That fed into a reported reduction in carer breakdown risk. So that ability for a carer to have a break. One thing that Eric says in another part of the interview is for the first time in years, he was able to go without feeling guilty to meet his friends and have a drink in the pub, because he knew that the way we'd set the system up, Claire could just call him through the Alexa by voice and it would ring on his mobile phone and they could have a conversation. Prior to that, she would have needed to have dialed the phone and she couldn't hold the handset to do that. So that just gave him that little bit of extra breathing space away from Claire to make sure that he wasn't at greater risk of that carer relationship breaking down. We did only see a direct reduction in the cost of care in a couple of cases. In both those cases, it was relatively small. So I wouldn't say that this was a particularly good way to avoid carer costs. What it did do is it had an impact on informal carers. So the point above probably is more applicable here than the opportunity to reduce reliance on maybe a paid carer. Mark mentioned that we had to be very clear about the data implications of this. The only way we could set this up, and we did go into this at some length with Amazon, was that the individuals had to have an Amazon account. And if you've got one of those or an account for a similar service, you'll know that you're effectively required to sign away the fact that your data is being collected. Every interaction, everything you ask it, is collected and held in the cloud. And we did identify for people how they could find and delete that if they wished to, but they were very clear that was what they were signing up to. And only 3 in 10 actually expressed a concern about that, and actually only 2 people that we approached said when they had that explained to them that they didn't want to proceed. And my sense is that probably reflects the kind of the wider population's view of privacy, that there's increasing acceptance that if you want free access to the news, the weather, information, advice, answers to questions, whatever it is, then there's a quid pro quo, and that quid pro quo is the organisation providing that information will take your data. You can always go in and delete it if you wish to, but that's the nature of the deal. All the users that were involved in the pilot have kept their devices, and in fact several have purchased additional devices because they found it so useful, and it was a revelation to them, and they wanted then to have another device in another room and connect them together and really get greater benefit from the technology. Okay, thanks, Mark. So the lessons that we learned from that, user selection is critical. Mark said that went through the breakdown of the different types of people that we gave these to. What he didn't say was when we first put the idea together and went to the LGA to say, would you be interested in funding this? We had thought that we would be giving this to people who maybe had early signs of cognitive decline, maybe learning disabilities. Actually, when we got into it, we realised that that was probably the wrong target group, and we ended up with the kind of physical disabilities and sensory loss cohort that Mark's described. And I think that is quite critical. You have to be realistic. If somebody has got cognitive decline, the chances of them being able to interact with a device like this might be quite low. There's the potential for confusion, and you've therefore got to be quite careful who you give it to. So it absolutely isn't a kind of, well, let's just give this to everybody on the social care radar. You have to carefully select. Desired outcomes vary very widely. You saw with Claire there just the ability to control lights, listen to Barry Manilow, have it read a book, where what she wanted to achieve, maybe take a bit of pressure off Eric. We had other service users where their objective was to manage their own shopping, maybe control some other appliances, quite specific things that needed to be teased out in the conversation with the service user. The GDPR and data thing, as I've said, it is a concern, and it was presented as a barrier by some that were involved in the early part of this project. What we found was there are ways to address those concerns. You have to be transparent, you have to be clear and honest with people, you have to be realistic about what happens to data, and once you are, people can then make an informed choice of their own. Setup time can be very considerable, so this understanding people's needs and that word that Mark used, curating the solution so that it did exactly what that person needed it to do, is not a simple thing. This is not a 40-minute tech install for a Lifeline independent. Some of these visits and setup visits were half a day. And then some of those service users were still quite high maintenance, so they did need us to go back and or help them over the phone with issues. And if you haven't got the infrastructure or the desire to provide that level of support, then this is perhaps not something to look at as a routine or mainstream offer. Developing new stuff is unnecessary. That relates to an objective we had at the start to develop a skill to do a particular thing, and one of those things actually was repeat reminders. We wanted to be able to give people a recurring reminder to take medication, so it would, Alexa would say it's time to take your medication at 9, 12, 3 and 6 or whatever the regime was for the day. Just at the point where we'd worked on that and spent time and energy making that work, Alexa released that as a function out of the box. Obviously they didn't tell us in advance, we learned it at the same time everybody else did, and that really made that work a bit wasted, and I think the same would be true looking forward. If there's something it can't do at the moment, it doesn't mean it will never do it. Amazon are changing, well, not just the software but also the hardware on a regular basis, and there is always something in the pipeline that you can use, and it's about exploiting what it can do rather than second guessing a global organization like Amazon and trying to outdo them with new ideas. And finally, users in the media love this. The users thought it was fantastic. We've got lots of videos and other testimonials from people saying how it's transformed their lives, given them back some independence and control. And it's one of the few things that I've been involved with in the last 10 years working in care technology, where we've been more or less inundated at the time. This was going go back 18 months or 2 years, by the BBC, by the Guardian, by various sort of sector media outlets for information and news about this. It really captures the imagination. And if one of the tasks you're seeking to achieve through your digital festival is to raise the profile of technology and how it can play a part in care, then this is a great way to do that, because it's very relatable, and it's not stigmatizing like some of the more conventional care technology solutions can be. So people like the idea and want to know more about it. Okay, Mark. Next slide. Mark, are you able to move the slide on?
Sorry, I had a problem with that. Can you hear me?
I can now, yeah.
Right, okay, sorry.
It's all right.
I would. It's stopped sharing. Bear with me. It was the questions and
yeah, okay.
Slide. So there wasn't another material one. Do you want us to continue on or answer some questions now, Kim?
So we have one question from James Montgomery at the moment. So perhaps it's something you would like to answer now, Steve?
Yeah, go ahead. I'm not seeing those questions, by the way. I'm seeing Mark's screen again. Could you read it out?
I'll stop sharing.
Oh, we got those there.
That's Chris's screen. That's not mine.
Oh, is it? Right.
Yeah.
Okay.
So James has asked, or explaining, we have an established hospital discharge process, issuing clients with temporary alarms and then carrying out a full service review. I would be interested to know how clients' details are shared between hospital and control centre.
So when we set up the device, the device is actually set up live with the service user by the discharging, the member of staff making the discharge. So the basic data is actually sent through the phone itself. So we call the monitoring centre on the SOS phone, say, and they've got them preset in the monitoring system. They then enter the data for that individual name, address, and the basic details. We then give that phone to the service user, and it works from that point. And when they get home, we ask them to press the button again, partly to test that they've got signal in their home, because obviously the initial call was made from the hospital. But then we also ask them a series of additional questions and fill in some of the other material we need, like nominated responders or additional phone numbers and so forth. So it's a kind of two-step process. There isn't any data shared in the sense of formally sending data from the NHS to ourselves. It's literally done as a phone call. Okay.
Thank you.
Right, I'll attempt to share the next presentation, which is the cobots one. Bear with me. Right, I think you might need to do that, I'm afraid, Chris, because my sharing thing's gone funny. Okay. Right. Is that okay? Are you okay driving that then, Chris? Yep, brilliant. Thank you. I can't see it now. Brilliant. Okay, right. I'm just going to give you a couple of an introduction to this, and Steve's going to pick it up, and we've got a video about the cobots at the end. So this again is starting on the theme really in terms of how we approached this. This is us looking at a problem we had, which was how do we both support carers in the provision of their care duties, but also how can we address a potential shortfall in the care workforce going forward over time. So if we can move forward, please, Chris. So what we're going to talk about in this session really is what the problem we were looking at, what we did, what the results and benefits of work were to date, and the next steps we're taking to use cobots in care settings. And I think you'll see that there's a little asterisk after that. It's a computer-controlled robotic device designed to assist the person. That's the official definition of a cobot. So so that's all useful. So if you move on, please, Chris. Right, so the problem we're seeking to solve. So we had an impending crisis in care. So we're facing an increasing growth in the volume and complexity of demand. And in order to meet that, we're going to need to find, we estimate, an additional 6,000 more care workers needed by 2025. So over the next 5 years, we need to see in place, given the pattern of care delivery that we've currently got, an additional 6,000 individuals. We also saw that a third of our packages are now double up care. So given that complexity, but also given the patterns of behaviours about assessing and putting in place and prescribing care, and I think those last points are quite important for us to acknowledge, is that actually we've got a significant number of double up packages of care. And we're also concerned about the resilience of unpaid carers and the risk of further demand for funded care. So those were all issues that we wanted to see how we could look at. And the question we started, those were the questions we started was, this wasn't a, oh, we've got this cobot device, what can we find to sort of like do something with it? It was actually, we really did start with these sorts of questions in mind. So if you hit the button again. So in 2018, we won further funding to explore how carers could be better supported with the physical aspects of care. And that's where it started really, is what could we do using technology, because that's what we're about, to address these sorts of issues, and that overriding one there. So if you move on. We undertook a number of workshops with carers and long-term care receivers, and what they revealed there was that carers were struggling with the physical demands of caring. So if you talk to carers, and I'm sure a number of you do on a regular basis, one of the things they'll say that at the end of the day, they're tired, they're beaten up, they ache, they've got bad backs. You often see people who are been caring for years just saying, I'm getting to the point where I can't do this anymore, and that there was a real issue for people. And often, actually, they often see a lot of things happening around them, and that for carers themselves, they often felt very unsupported in the environment. In that, we talk about technology, and a lot of technology is very rightly cared for, person focused. And there's not a lot that we see with carers being delivered for them, that enable them to deliver the care, apart from the sort of old traditional stuff around hoist and stuff like that. So it was an option for us to actually say, well, what could we provide for carers that was to support them, to enable them to do their job in a more effective, better way, and look after their health and well-being at the same time. And that we found that people were receptive about the idea of robotics and how we could potentially use those. So I'll hand over to Steve to talk about what we did.
Okay, thank you, Mark. Actually, Chris, this has got several fly-in bullets. You might as well put them all on. I'm going to go reasonably briskly because we've got a video which this will all make much more sense, I think, if you were to see the video, and we want to leave some time for Q&A. So first of all, there was a strategic business case developed which said what might it look like if we were to support people who have physical care needs, and what solutions might be out there. We focused on that very specific use case. This turned out to be very important because when we started looking, there are lots of different potential use cases for a cobotic device, and the device that you would design if you were doing it from a blank sheet of paper would be really quite different. So Does this need to go in the boot of a car? Does it live in a particular location? Does it need to be wired to the mains? Does it need to be attached by a wire to the ceiling because it's a big heavy thing? Those things make a massive difference, and it starts with what's the use case. So it was very clearly around that double up care challenge. Following a global trawl, we found 40 developers of devices that looked like they had potential, many of them designed for different purposes, often manufacturing or defence or mining and engineering. We did find a few promising providers, and from one we borrowed a device for show and tell sessions. Can you click a few more in, Chris? So when we got that across and we showed it to people and people were able to try it on, the level of enthusiasm really grew then, because people could see that how this might actually work. We then needed to engage with external bodies, because we knew that if there was a sense that people like CQC or the Health and Safety Executive were going to put the kibosh on this, that there was no point in starting. So we were and continue to be engaged with those organisations to make sure that they are sighted of this and also enthusiastic. And in fairness, organisations like UK Healthcare Association, who represent dom care providers, are very enthusiastic, because it's their members who are exposed to the kinds of musculoskeletal problems, risks and injuries that this device can help to mitigate. Once we got to that point, realised there was some mileage in this. The council then leased six cobots. We got them from a company in Japan called Cyberdyne, imported them, and we've been deploying them in care settings. In the midst of COVID, we had to stop using them in residential facilities and convert them to community use, so they were then being used with individuals rather than in a residential or a nursing home setting. And we had a very extensive evaluation framework to track what impact it was having if you wore one of these cobots for your shift as a care worker. Okay. Oh, and then obviously updated the business case in the light of the findings, and that's just been done, and we've gone back to the management team in the Council Adult Services Department to talk about next steps. Okay, next slide, Chris. So in total, we had the 6 cobots. They were used by 18 different carers in 6 different settings, and you can see that in most of those settings, in terms of these 4 horizontal considerations of performance, the impact on people, the technology itself, and operational training, it met the objectives that were set for it in advance. We were very clear what we wanted to see, and then we measured that and made conclusions about how effective it was in each of those contexts. Next slide, please, Chris. So this expands a little bit. I'm not going to go through all of this. I'll pick out 2 or 3. Expands on that idea of how do you expect this to work? What impact are you expecting it to have? So let's pick out technology there, so 3rd down on the right hand side, we were testing whether the cobot was easy to use. Is it easy to put on and off? How long does it take to do that? What happens if you need to swap the battery, if the battery runs out partway through your shift? Does it fit? Is it available in a larger size? It's a physical device that's made in one size at the moment, and it simply didn't fit everybody. So we needed to evaluate what difference it would make if a larger size was available. On the, can we just go back? So bottom left, finance, looking at the cost of double up care packages and the possibility that a cobot on one carer could achieve the same outcome safely was how we evaluated the financial impact. And you can see that's an orange tick. It wasn't a green tick on the others. It's in order to get a return on investment here for what is an expensive device, you really do have to be very focused on getting it in use for the right person, the right carer, the right service user, and making sure that you're replacing a second carer wherever you can, wherever that can be done safely and sustainably. And then the top left there, governance and regulation, as I mentioned, big issue about ensuring that regulators are sighted of this and aren't going to come in at some point and say, well, this is not acceptable and you're not to use these, because that would make the whole thing a waste of time. But they, I have to say, have been very supportive and positive and even enthusiastic. They can see the benefits of this kind of approach. Okay, Chris. We've just used a quote here. I have to say, this is quite typical. We got feedback like this from lots and lots of people who wore it. It's a couple more lines, I think, Chris, if you want to carry on clicking. this reference to dreading double up. So this is a care worker. I think there's one more line that says who this person is, Chris. Reablement care worker. So this is somebody working day to day in reablement, often in the double up situation, and clearly was dreading those because of the risk to themselves of injury and just the complexity of doing it. They now don't think of that as strenuous anymore. It doesn't feel like hard work. And they were able to do things independently. We had quotes from social workers and others who wore it and said at the end of their shift they felt like they could do another shift. They slept better. Lots of really positive impacts. Okay, next slide. It says questions and discussions. I think we should show the video, Chris. We've got about a 2-minute video. That should leave us just a couple of minutes at the very end for questions. But if you can be saving those up while you're watching the video, which may answer some of the questions anyway, because it all becomes clear when you see the thing in use, then we'll pick those up at the very end.
I was able to really see a difference, like working with service users, wearing the cobot and not wearing the cobot. So when we were doing heavy moving and handling positions, the support I got from that was absolutely amazing.
The task that I find it more helpful wearing it is definitely repositioning residents, rolling, moving position in the bed.
With residents that may need a little bit more support, I feel like I can roll them and support for a lot longer. It makes me think about what I'm doing. So if I wasn't wearing this, I would probably outbend or twist in a way that I shouldn't.
The service users have been very, very interested in this piece of equipment. And we were a bit worried because some of our residents do have dementia and we thought they might be a little bit apprehensive, a bit nervous, a bit scared, but they've been really interested. They've been asking questions. It's been very positive.
When the residents see this, they're like, oh, it's clever, brilliant idea.
Having a piece of equipment that would look after a care worker, support them in their daily life to prolong their journey in care is a win-win.
One of my colleagues actually wore their cobot all day. After her shift, she actually said, I'm ready to do a whole other shift.
It does feel like an exoskeleton.
I sleep better because I'm not aching the whole day, hasn't been like weighing down my shoulders and back. It feels good.
You all know there's a crisis in
Okay, thank you for that. Kim, do you want to, in the last couple of minutes, throw some questions our way if we have any?
Yep, sure. So just as a group, please do feel free to type your questions and they will be answered. There was a question that came in just after the last segment that you had completed, and it was, what were the reasons for the two people saying no to the technology? Did the issue of cost come up, such as B&B if required, or Wi-Fi?
Right.
Yeah.
No. So the reason, it was a data related thing. So it was linked to the previous point about 3 in 10 people expressed a concern about data privacy, but proceeded anyway with the trial. Two people who had a problem with data decided that was a reason for them not participating. The cost thing is interesting. I think Mark mentioned in his part of that session that really having Wi-Fi was a requirement for this. So we wouldn't, the council wasn't in a pilot phase going to go out and give people broadband or Wi-Fi. That does mean some people can't have this, and that's unfortunate, but that was the way it was. If they had Wi-Fi, they could do this, and there was no cost. There was no cost for them for the device, and there was no cost for them to have an Amazon account. So to extend that, you know, you can add on Amazon Music and Amazon Prime and things. You don't have to do that. So actually, as Eric says in the video, once you paid for the box, which they didn't have to do, if they already had Wi-Fi, there was no cost to this at all.
Can I just add to that as well? I think the issues that that were really thrown up about this was the interconnectedness with other areas of interest. So the whole issue around superfast broadband and accessibility of that was really key. This issue of curation, one of the things that we were really keen to do is to start to use community resources to support people, and things like our library services and stuff like that. And you start to get into areas of thinking beyond the traditional tech service when you start to enter into this. And the issue here isn't cost, it's the effective use of resources and thinking about resources you've got to hand to be able to support you to deliver these sorts of things, which are really quite critical. And again, it goes back to the point we keep making constantly, is effective tech services are often less to do with the technology itself than to do with the human element of it. Those are the really critical elements that make a difference.
Excellent. I cannot see any other questions that have come through. So obviously we're right on time. So all I would say now is, Mark, Steve, thank you for your time and sharing your journey with us.
Not a problem.
You're welcome.
Pleasure to be here.
Yeah. Good luck with the rest of your digital festival.
Thank you.
Cheerio. Bye bye.
Thanks a lot. Bye bye.